said, I want to introduce our keynote speaker. Introduce our keynote speaker, Dr. Burt Berkson, from my heart to yours. And truly, I have had Dr. Berkson come to other conferences. He has been so kind to come across the country and speak. And Dr. Berkson, to me, is the angel of hope and giving us truly concrete examples through his patients where low-dose naltrexone and alpha-lipoic acid have people alive and well who, by all terminology and prognosis, should have been passed on long ago. And with this, I feel that we have the best speaker, the best opportunity. Our speakers list is shorter this year, but it's always quality and not quantity. And Dr. Berkson, I put you on for 2 hours because I wanted you to have all the time to say everything you want to say and need to say to this audience, and for them to be able to ask you the questions and receive the answers that they came here for. Please join me in welcoming Dr. Burt Berkson.
Thank you. It's a pleasure to be here. Today, I'll be speaking about low-dose naltrexone, protocols for autoimmune disease and cancer. I have a medical degree, a master's degree, and a PhD in microbiology. Never thought I'd ever practice medicine. I thought I'd always continue as a professor. But years ago, by the way, this is where I'm from, Las Cruces, New Mexico. It's very pretty there. Years ago, when I was a medical internal medicine resident in Cleveland, Ohio, at one of the university hospitals, I was asked to take care of some people with terminal liver disease. And I was told that these people would die, nothing could be done. And my task was to watch them die and take notes, present it to grand medical rounds. As a medical doctor, you're supposed to follow the orders of the chief. But PhDs are always looking for new things, and I had been a professor for several years at Rutgers University and the State University of Illinois. And a PhD is always looking for new things. So I called the National Institutes of Health and spoke to the head of endocrinology at that time and kidney disease and diabetes. And there was Fred Barter, Dr. Fred Barter. And I asked him, I had known him because I had had a grant through NIH years before, and I asked him if he knew of anything that would regenerate a liver. And he told me that he thought alpha-lipoic acid would be the miracle drug for the reversal of complications of diabetes. And he was studying it for diabetes, but he said when he gave it to people with diabetes, they seemed to not only regenerate their blood vessels and nerves in their feet and their eyes and other parts of their body, but their livers seemed to get better. So he sent me the lipoic acid. I ran down to an airport, picked it up from a commercial pilot, ran back to the hospital, injected it into these two people, and within 2 weeks they regenerated their livers. And Dr. Barter was very happy. I was all excited. The chiefs were angry at me. They said, I was told that you can't do these things in a hospital unless you get previous permission to do it. And I was very naive medically. I just thought you do the best thing for your patients. And they had told the families the patients would die, and they were alive and well. Incidentally, that was 32 years ago, and they're still alive and well without any liver disease. Told by one of the chiefs that, do you want to make us look like fools? Well, years ago, I wrote a book, which is still my favorite book that I wrote. It was one of my books. It's called The Alpha-Lipoic Acid Breakthrough. And in the foreword, Dr. Julian Whitaker from Newport Beach wrote that many doctors he knows would rather have their patients die than try something different. Well, this is Dr. Barter and I and Barry Rumack when we were invited to Germany to be visiting scientists at the Max Planck Institute in 1978. This was after we published a paper on the reversal of 75 of 79 people who were actually waiting for liver transplants with just intravenous alpha-lipoic acid. That was over 30 years ago. I was appointed the FDA principal investigator for this as a drug. Cheap, very effective. Nobody is interested, or very few people are interested 30 years later. One of the worst damaging agents to the liver are Amanita mushrooms. And one of the reasons I knew about this was because my PhD is in an area of microbiology called mycology, and I was an expert on mushroom poisoning, and I'm still the consultant to the CDC on lipoic acid and liver toxic mushroom poisoning. This was our original paper that we published, thioctic acid, which is another name for alpha-lipoic acid, the treatment of poisoning by this horrible, horrible toxin, alpha-amanitin. Barter, Berkson, etc., from National Institutes of Health. Then in 1999, I was invited by the Internal Medicine Society of Germany to talk about my treatment of hepatitis C with alpha-lipoic acid. And in that article that was published in 1999 in the German Journal of Internal Medicine, Medizinische Klinik, I wrote, "It appears reasonable that prior to liver transplant surgery evaluation or during the transplant evaluation process, that the triple antioxidant treatment protocol should be considered." That's lipoic acid, selenium, and silymarin. If there is a significant betterment in the patient's condition, liver transplant surgery may be avoided. Well, this triple antioxidant process that I developed, this protocol, is actually very, very inexpensive. And I believe that liver transplants cost about close to $500,000 the first year. The patients I regularly see, I see many adult onset diabetes patients with neuropathies. Alpha-lipoic acid, especially intravenously, reverses this in many cases. I see many hepatitis C patients. Probably the majority of people I see are hepatitis C. They've been through the regular treatment with no good result. In fact, many of them develop heart disease, severe anemia, and liver damage from the normal treatment. Alpha-lipoic acid often helps these people live normal lives, and lipoic acid can actually, in my opinion, stimulate stem cells in the liver to regenerate normally. Many of the patients I see are autoimmune people, and I use low-dose naltrexone plus alpha-lipoic acid and other things too. And I see some cancer patients. All patients that I see are followed along with various specialists. There are informed consent forms. The conventional therapies are explained very carefully with complete objectivity. Most of these folks with cancer have been through the conventional system And probably most of them are told to just go to hospice, that they're going to die. Nothing could be done. Most patients that I see are considered end stage in cancer. Well, most of us know about CAT scans. It's a radiological test that demonstrates anatomy. It shows an anatomical feature. PET scans demonstrate physiology. For cancer, a small amount of radioactive sugar is injected into a blood vessel. Since many cancers thrive on sugar, the radioactive molecule goes to the cancer first, and when you take a picture, it lights up on the screen like a Christmas tree light where the cancer is. Well, many insurance companies do not pay for PET scans, so in this case we can only do CAT scans. This is a slide that I borrowed from the Mayo Clinic. On this x-ray, this person actually has cancer, but with a regular x-ray, it doesn't show up. With a PET scan, you can see these areas of early cancer with, they show up because sugar goes to the cancer, and the sugar is radioactively labeled. So you could see it much better than with a CAT scan. Well, there are many types of pancreatic cancer, and they differ in severity. Our first patient is Mrs. G.B., 74-year-old woman who's a patient at a large California medical center. I first saw her in September of 2006. She had biopsy-proven pancreatic cancer. She told me that her religion does not allow standard medical treatment, and several of her friends have died from chemotherapy. Her doctors told her nothing could be done. My protocol, I combine low-dose naltrexone at bedtime with intravenous lipoic acid. All patients are prescribed a high green vegetable diet. Many are on several vitamin supplements and herbs. They should be on some type of exercise program. I like the sun. Sun tanning is fine, but not burning. And I prescribe some type of relaxation and good night's sleep. If they have trouble sleeping, I prescribe something that breaks this anxiety cycle like Ativan or Xanax. Probably about half of what I do is conventional standard medicine, and probably half is integrative medicine. The protocol is low-dose naltrexone, 3 to 4.5 milligrams at bedtime. When a person first comes in, we do intravenous alpha-lipoic acid, 100 to 600 milligrams IV, for maybe a week or 2 weeks, and then every 3 to 6 months, depending on the patient. And I use our original National Institutes of Health protocol that Dr. Barter and I developed years ago. We want them to have a healthy lifestyle and nutrition program. We want them to be very adherent to the program. Mrs. GB was very adherent to the program and still is. Other people will talk about how naltrexone works. Most of us know the theory. A lipoic acid does many things. Probably the most important action of alpha-lipoic acid is that it's the rate-limiting factor for the production of energy from food. Food cannot get into your mitochondrion where it's burned for energy. It's converted to something called pyruvate. Pyruvate can't get into your cell. The fuel for the mitochondrion is acetyl coenzyme A. There's an enzyme complex called pyruvate dehydrogenase, but this does not work without the trigger, which is alpha-lipoic acid. When we're little kids, we produce plenty of lipoic acid. In our own bodies, as we get older, we produce less and less. If you feed a little child a Thanksgiving dinner, he has plenty of lipoic acid, he'll be running around the house afterwards. If you feed an 80-year-old man who produces very little lipoic acid in his cells, he'll be sleeping on the couch. If you give him some lipoic acid, he'll probably be walking around the house. A lipoic acid is also a free radical scavenger. It's an antioxidant cycler. In other words, when vitamin C and vitamin E and NADH and all of these things are used up, lipoic acid converts them back to the useful form. It's also the greatest generator of glutathione, which is the most important antioxidant in the body. And here's the lipoic acid. This is how it fits into this complex for the production of energy from your food. So a very, very essential molecule. And many people in the anti-aging industry use it, especially in Europe, for anti-aging. It's a prescription drug in Europe. Here it's a nutraceutical. Well, this is Mrs. GB when she came in. Here's her liver, and her liver is full of metastases. And here is the cancer in her pancreas, full of cancer. This is September 06. In June of 07, the liver appears free of metastatic disease, and I don't see anything in the pancreas. This is just some of the contrast medium being pumped through the heart and accumulating in the bladder from the kidneys. This is March of 08. No sign of pancreatic cancer. Mrs. GB, September 06 to October 09. Feeling well, no signs or symptoms of cancer of the pancreas, more than 38 months following diagnosis. This case will be published with 2 other cases in December of 09. Mrs. JK, pancreatic cancer, 80-year-old woman from California. The CT scan showed pancreatic head tumor with possible liver involvement. Diagnosis 2005. Her cancer tumor antigen was very high, 356. She refused chemotherapy. She was a patient in San Francisco. When she first came in, here's the cancer of the pancreas, and you could see the beginning of numerous tumors in the liver. January 06. She actually stayed for 6 months. In June of 06, no sign of pancreatic cancer, and the tumors in the liver appear to be mostly gone. She returned to California in August of 06. Her doctors refused to provide the therapy. Her pancreatic cancer reoccurred. She was told she had pancreatic cancer, nothing could be done, and she died in November of 06. I spoke to her personal doctor, and she told me that she really wished she could use it, but she was very concerned that doing something this different, even in her office, might cause other doctors to look down at her. We have many patients with very, very severe pancreatic cancer, with livers that are almost full of metastases. They've been through the whole system. I usually recommend to these people that they stay with their own doctors in their own area, and I suggest ways of treating them. But sometimes they actually come in, like this is a patient, Mr. WJ, who came in this year, and his whole liver is full of cancer, completely. And there are tumors in the pancreas. I don't know if we could help him. Here's another one who came in this year, Mr. CJ. I discouraged him from coming in. I spoke to his doctor, suggested some treatment strategies, and I suspect his doctor was concerned about doing these things because it was different. But he's still alive, by the way. My first patient was Mr. J.A. He had pancreatic cancer with mets to the liver. I first saw him in October of 2002. There's a gigantic tumor in the pancreas. With metastases to the liver. At that time, his insurance wouldn't pay for PET scans, so these are CAT scans. Following diagnosis in his hometown, J.A. was sent to an oncologist for chemotherapy. He had a 21-day course. He developed a very low white blood count. His platelets were down to almost nothing. The oncologist told him that there was no hope, he would die very soon, and he was in his early 40s. J.A. sought a second opinion from MD Anderson Hospital. After a complete workup and review of the records and biopsies, the patient was told his condition was hopeless. November 2002. He presented to our office. His wife actually dragged him in. He didn't want to be there. He was very depressed. He told me he did not want to die at 46 years old. He had a young son, wanted to see him grow up. I told him that I tried to develop a program that might make his life a little easier. This was my first pancreatic cancer patient. And I didn't know if this would work, but he didn't live far from our office, so I thought we'd try it. Gave him low-dose naltrexone, intravenous lipoic acid twice a week. Put him on a healthy lifestyle program. He took some drugs that I gave him. For example, I gave him Xanax at bedtime to break the stress cycle, and a few other nutraceuticals. The course of events were uneventful. As the patient continued on ALA and low-dose naltrexone, he went back to work full-time in 1 month and told us he's beginning to feel normal at that time. As J.A. continued his treatment, follow-up CAT scans were ordered at regular intervals. Both the CAT scans of April 2003 and June 2003 revealed no changes in his pancreatic cancer, no growth, and no new lesions. It was still there in 06 and still there in February of 06. That's in the liver. But this cancer was not growing, and it didn't seem to be active. August of '08, we were very surprised to see that the tumor in the pancreas had disappeared. And the liver was scarred from the old tumors, but they weren't there anymore. J.A. felt so good that he stopped the IV lipoic acid, but continued to take the low-dose naltrexone. His oncologist said, "This must be carcinoid syndrome rather than pancreatic cancer." The oncologist said, "MD Anderson was wrong. No one with pancreatic cancer could be alive for so long." So he was put on a treatment for carcinoid, which is a neuroendocrine tumor, called RHEUMATOID. And Mr. J.A. stopped the ALA treatment and low-dose naltrexone. In July of '09, he came back to the office. Once more, he was full of cancer. This is a PET scan. J.A. started our protocol again in August of '09 and feels good once more. Diagnosis of adenocarcinoma of the pancreas with metastases to the liver in October 2002. Mr. J.A. is alive, working and feeling normal 84 months following his terminal diagnosis and watching his child grow up. This was published in Integrative Cancer Therapies in March of '06. Mrs. J.A.L., 60-year-old nurse. She had hepatitis C and cirrhosis of the liver. She developed a big mass in her liver, and it was identified as cancer of the liver. This was in 2006. And here is her PET scan. The liver is just full of cancer. Her doctor said nothing could be done, she should go to hospice. She came in. I didn't know if this would work, but this was her last resort. This is in 2009, no sign of cancer. Liver's completely free of it. And she's back at work doing fine. Mrs. T.E.S., a 47-year-old radiological technician, had severe rheumatoid arthritis. We treated her with ALA and LDN. She was not completely well. She was really sick. She went on Humira, which is a biological response modifier from a rheumatologist, and her lymph nodes increased in size. Many of these biological response modifiers turn off the immune system. So if somebody is prone to cancer, they can develop cancer from this. We did a PET scan, and it shows big lymph nodes in her groin and under her arms. And she was diagnosed as having a lymphoma from the drug. We took her off the Humira, we put her back on LDN, and this PET scan shows she still has the big lymph nodes. In April, by September of '09, they're gone. And this was a B-cell lymphoma. Mr. TM, I presented this case before, a B-cell lymphoma, biopsy proven at a big hospital in Chicago, 2004. I actually urged him to have standard therapy. He refused because he had been through other things before. A biopsy proven 2004 in Chicago. He only had 2 weeks of intravenous ALA. However, he continued his low-dose naltrexone at bedtime. He did not follow any of the other programs. In December 2005, big lymph nodes in his neck. This is backwards. Under his arms, here's the liver, that should be the right side. And a gigantic tumor, 2 tumors in his groin, his left groin. By May 2006, no sign of cancer. This is just accumulation of the contrast media in the digestive tract. The body's getting rid of that contrast medium. The patient did not continue therapy. He did not go to his oncologist. Lymph nodes under his jaw increased in size. He saw the oncologist, however, TM once more refused standard therapy. He started back on the ALA and the low-dose naltrexone. The groin lesions gone. I don't know if this might be a lesion under his jaw. A patient not adherent to ALA and probably not taking his LDN. This is January of 2009. And guess what? The lymphoma's back. Well, this was published in 2007 in Integrative Cancer Therapies, Reversal of Signs and Symptoms of a B-cell lymphoma using only LDN. It was accepted in 2007. Mrs. D.D. had aggressive breast cancer. She was told she would die very soon. Nothing could be done. We treated her from August 2007 to present. And this is a graph from the laboratory, and it shows the various tumor markers in 2007 and where they are today. And they fell to practically nothing in 2 years. And she's still doing well. Her oncology folks said that she didn't have long to live in 2007, probably be dead within the year. She's back at work and doing fine. Well, I find that for cancer, a few people do very well, many don't. But LDN works really well for lupus and rheumatoid disorders. The standard treatment of autoimmune disease has some very serious adverse effects. Now, dermatomyositis is a very serious autoimmune disease. Presumably, the patient's T cells inappropriately recognize their muscle cells and skin cells as antigens and attack this tissue, causing degeneration. With dermatomyositis, there's often a rough, red, raised rash. And here you could see immune cells eating up the person's muscle. Here are the immune cells, and here's the muscle tissue. And their own body is destroying their own muscle tissue. The prognosis of this disease, 20% die in the first year. In chronic forms, people often live 2 to several years. These patients often have cancer, and this is a paraneoplastic syndrome. It's something that occurs in certain people with cancer. If you remove the cancer, sometimes the dermatomyositis disappears. Mr. W.J. had an extremely serious case of dermatomyositis. 48-year-old rancher from New Mexico. I first saw him in October of 2007. We did CAT scans. They did not show cancer. The problem started in fall of 2005, and he progressively became weaker, developed this horrible skin condition. When he came into the office, this fellow was about 6'4". He had to be carried in by his two sons. He couldn't even walk. The rheumatologist put him on prednisone, which is a steroid, Celsep, which is a fungal toxin, which destroys part of the immune system. They often give this to people with transplants. Imuran methotrexate, originally a chemotherapy. Remicade, a biological response modifier. He kept getting sicker and sicker. His teeth fell out. He was a muscular man. He was losing muscle, and profound weakness and severe anemia. His doctor told him he probably would not live that year. He would die within a year. He went to a big medical center, and they agreed with his doctor. Nothing could be done. His CK, when I saw him, which is the creatinine kinase, which is a marker, a test for that shows muscle degeneration, was 2,573 units per liter. His pain scale was 10. He was in constant pain. This was in October 2007. He was told he would die by Christmas, and he didn't want to be there. He was dragged in by his family. December of 2007, off his standard drugs and on our protocol, his creatinine kinase fell from 2573 to 573. And his pain scale fell from 10 to 2. He was feeling normal. He was back at work as a rancher. In 2008, 12 months later, his pain scale was 0, and his creatinine kinase fell from 2573 to 100. The rash disappeared, and he's feeling strong and normal. Today, 24 months after presentation, he put his weight back on. He's very muscular. He's on his horse every day. He's throwing hay in the barn. He's fixing wells, working sometimes a 12-hour day, feeling normal in every way. Rheumatoid arthritis. With rheumatoid arthritis, people have an elevated rheumatoid factor in most cases. Symmetrical arthritis, especially of the peripheral joints with pain and swelling. Pannus development, which is granulation tissue, which stimulates inflammation with a resulting loss of cartilage and bone. Extra joint manifestations such as heart disease, other blood vessel diseases. X-rays show loss of bone in the joints, narrowing of joint spaces, erosion of the joints. And this is an early case. This is the hands of one of our patients. Goes on for a long time and starts looking like this. Mrs. AE. This is the same patient I presented before. 47-year-old radiology technician, rheumatoid arthritis plus systemic lupus. Perfectly normal until she had dental implants in '99. And soon afterwards, she developed autoimmunity with severe joint pain. previously treated for many years with normal therapy, developed bone loss, anemia, etc. Enbrel and Areva cost her $1,800 a month with terrible results. The Humira actually caused her to have a lymphoma. She had very little relief. She presented to our office in July of 2005. Her rheumatoid factor was almost 1,000. Her antinuclear antibody was 1,446. She wanted to try something less toxic. Her pain index was 10. We weaned her off the rheumatology drugs. She continued with visits to her rheumatologist. He was very angry that she stopped these things. He told her that she had terrible autoimmune disease, nothing could be done. Put her on low-dose naltrexone at bedtime. Alpha-lipoic acid intravenously twice a week. And I put her on the antibiotic minocycline, 100 milligrams every day, and with a healthy lifestyle. In June of 2006, 11 months later, her pain index fell from 10 to 2, and the patient feels almost normal. Her rheumatoid level fell from 969 to 131. Her ANA fell from 1446 to 131. Mrs. A today, 50 months later, very little joint pain on ALA and naltrexone. She's also on some Motrin. And I changed her minocycline to Biaxin, clarithromycin, 250 milligrams every day, and she also takes probiotics. Pretty normal most of the time. She has severe osteoporosis from the steroids that she was on for many years. Here we could see some typical patients with rheumatoid arthritis and their original rheumatoid factors. And within 6 months to a year, we see these kind of falls in rheumatoid factor. And here's just some other patients. LDN seems to work very, very well for systemic lupus. SLE, systemic lupus erythematosus, predominant in women, usually a positive ANA. It's a multi-system inflammatory disease. It can be caused by drugs or toxin-induced. Some people are genetically prone to this. This is the typical rash of somebody with SLE. This rash usually does not occur in the nasal labial folds. Some of the manifestations of SLE, problems with the lung, heart problems, kidney, lupus nephritis, arthritic problems, problems with Raynaud's. And this is the glomerulus of a kidney. This is often affected in lupus and can be very serious. Mrs. RAR, a patient with SLE, first seen in 2003, weaned off several drugs that made her very sick. They did not help her feel better. In 2003, her ANA was 1280, 1 to 1280, that's the titer. 2009, it was 0. Here's a group of people with systemic lupus, and when we first saw them, they had a high ANAs. And within a short time, in most cases, their ANAs fell dramatically, and the people felt much better or completely normal. Then the other day, I took 56 patients at random that seemed to be fairly adherent to the program. And over here, I averaged, I actually added up all of their ANAs and divided it by 56, which came to 700. And this is 6 months to 1 year later. I took all of the ANAs, divided by 56. You can see there was a dramatic change in ANA levels with low-dose naltrexone, plus in most cases ANA. So these are some very interesting cases. Several people who were diagnosed with terminal metastatic cancer are alive, and some are doing very well. They don't even know they have cancer anymore. They feel normal. Many are not doing well. Many have died. At one time, we took most of the local people who were told they were terminal, and oftentimes a relative brought them in. They didn't want to be there. I don't know, you know, once somebody from a big medical center tells someone that they have a short time to live, people often have a short time to live. They believe these folks and die on schedule. Other people are not that way and are very skeptical and cynical about big organizations, and often they don't die. The best low-dose naltrexone results we get are with autoimmune disease. Most improve greatly. You know, all new ideas result from somebody, an individual, observing something very interesting. For example, Dr. Zagan and Dr. Bahari. This was the front page of Lancet, the British Medical Journal. It says, if everything has to be double-blinded, randomized, and evidence-based, and in internal medicine they often say this, where does this leave new ideas? Some folks, if you're interested in reading some of my ideas, my first book was the alpha-lipoic acid breakthrough. And I just looked at Amazon the other day, and I saw it was, even after years in publication, it was #1 on the antioxidant books. When it was changed from a prescription drug to a vitamin, you know, the vitamin business, there's very little control over it. And there are all sorts of lipoic acid on the market. One Asian source that I know of was given to 6 people intravenously by a doctor in the West, and all 6 people fainted while they were receiving it. They passed out and they were sent to the ICU. And the doctor called me and said, what is the antidote for intravenous lipoic acid? And I said, what product did you use? And do you have a certificate, a COA on the product? He said, yes, it's 99% lipoic acid. And I said, you better send it for your own protection to a private laboratory and see what it really is. And this Asian product was 60% unknown substances, only 40% lipoic acid. So I suspect what these people were taking, what these people were given was mostly stuff, we don't even know what was in it, and that's what made them pass out. So the vitamin business, you really have to know who you're dealing with. You have to ask the company, probably the person who owns the company, if he uses prescription lipoic acid from Europe or commercial lipoic acid from Asia. Originally, it was an intravenous drug, an FDA investigational drug. If you take lipoic acid, it goes to the liver, if you take it orally. And most of it is used by the liver, and very little gets into the bloodstream. If you have a serious disease like hepatitis or diabetes, you're producing free radicals constantly in the heart, in the pancreas, in the liver, in the brain, everywhere. You're creating these free radicals which create tissue damage. If you take it orally, a little bit of this lipoic acid gets into the bloodstream. If you take it intravenously, you have pure lipoic acid traveling to all of the tissues of the body, including the nervous system, crosses the blood-brain barrier. That's why I like it intravenous plus oral. Our patients take it orally, and they take it intravenously. Well, originally, the NIH protocol was, we did it in various hospitals, was 25 milligrams intravenously 4 times a day. Then we went up to 100 milligrams 4 times a day. And this was for poisoning. And we had wonderful results with this. But as time went on, I increased the dosage. At the primate research labs, they did an LD50 study, and I'm against monkey studies. I like many monkeys better than some people. There, they found that probably the best dose is about 15 milligrams per kilogram intravenously. And they also found that if you get up around 90 milligrams per kilogram, you heat up the mitochondria so much that they explode. And big necrotic areas develop in the heart, in the kidneys, in the liver, in the large muscles of the legs, and other parts of the body. And the animal or person dies. I actually saw the necropsies, the autopsies on these animals. And at the university, I did the electron microscopy studies, which we hope to publish soon, showing how an overdose of lipoic acid could just blow up the mitochondria. I had nothing to do with the monkey studies, but I thought it might be a good idea to do the electron microscopy studies. And that there are 3 people involved, Dr. Vigil, Dr. Garcia from Emory University, and myself. And that should be out within a year or 2 when I get some time to. I have so much data and so little time to publish. I hope my son comes in with me next year so I'll have a lot more time. Well, there are many doctors in this country that do this, and most of them are members of the American College for the Advancement of Medicine. And they do these, they call them intravenous vitamin drips. And they can get alpha lipoic acid through a compounding pharmacy. And they can administer this to you depending upon your laboratories and your weight. And everybody, at my office, every treatment is tailored individually to the patient. It's nutraceutical. It's a vitamin. It's considered a vitamin now. Also, do you have Epstein-Barr virus syndrome? I believe that most fibromyalgia and chronic fatigue syndrome are just symptoms of Epstein-Barr virus syndrome. So I don't call fibromyalgia or chronic fatigue, I don't call them diseases. I call them symptoms of Epstein-Barr virus disease. And I think the most important thing you could do is do an Epstein-Barr virus test and see if you have this. Now, all of us in this room have Epstein-Barr virus in our bodies. When we're young, almost everybody gets sick from Epstein-Barr virus. Sometimes it's diagnosed as mononucleosis, sometimes it's not. And our immune system beats up this virus and sends it to a room and locks the door. As an adult, if you're under a lot of stress, day after day after day after day after day, and you somaticize this, your brain releases chemicals that affect your adrenal glands, which secrete high levels of steroids, and the virus breaks out of this little room and causes fibromyalgia and chronic disease, which causes a vicious cycle of more stress, more release of chemicals that cause pain. And if you could break this cycle, you could often cure Epstein-Barr virus disease. Off all of their medications if they went to do the LDN. All of them, yeah. I say if the prescription drug's working for you, stick with it, if that's what you like. We don't suggest anything to anybody. We are very objective. We tell everybody to stay with their rheumatologist or their oncologist, and there are several oncologists that I work with now and very interested in what I'm doing. The rheumatologists sort of get angry if they, the ones I know, if they get better on LDN. But before I see them, they have to be unhappy with their standard treatment. I think most people that are sick are deficient. And one of the reasons I stopped doing it, I used to do all of these exotic tests at one time, which were very expensive to the patient. And then they'd blame me for them spending so much money. And now I just do standard tests, usually that are that people can collect from their insurance companies on. I always do a vitamin D level. I think that's very important. A C-reactive protein, a homocysteine level. We could easily correct homocysteine levels with B-complex vitamins, and we could easily correct vitamin D levels with oral vitamin D.
One more question regarding ALA. What's the absorption rate on oral versus IV? Is 20% oral absorbed, or 50%, or do we know?
Okay, if you take a good lipoic acid product, within 15 minutes, you'll smell it in your urine. It'll have an asparagus-type smell. And everyone absorbs it. Everyone. I think it's absorbed in the stomach. It's gets right into the bloodstream almost immediately, and you'll smell it in the urine within 15 minutes.
And your 15 milligrams per kilogram, is that per day?
15
micrograms?
You know, I can't give you any specific dosages because I don't know the patient. Everybody's different. Yes, sir.
May I ask if there's any brands of products that you like?
Yes, but I won't tell you what they are. just make sure that you ask your vitamin company if it's European prescription grade. I was once asked to write some articles for R-form lipoic acid. And I asked the magazine, it was actually several magazines, but I'll talk about one case. And I also asked the manufacturer of the R-form 3 questions. The first question, you know, lipoic acid, most lipoic acid, prescription lipoic acid in Europe is R plus S form, the synthetic plus the natural lipoic acid. The 3 questions were, number 1, do you use the prescription product as your initial raw powder, or do you use some industrial product from Asia? Number 2, how do you separate the R form from the S form? Do you use toxic hydrocarbons? And if you do, are there residues of this toxin in your final R product? Number 3, if the R form is so great, and I think it is theoretically, why is the prescription drug in Europe still the R plus S form? And I've done some work for the company that produces it in Europe. Years ago, I received a grant from them, and I went on a lecture tour for Asta Medica, who originally produced it. And they told me that it was very difficult. They actually owned the patent for our form. Very difficult to get the chemicals that they separate the R form from the S form out of the R form product. That's why they still use just the original R plus S, the racemic mixture. That's why I don't use R-form lipoic acid in my practice. The important thing is make sure that who's ever making this stuff is getting it from Europe, and it's, I think R plus S is best. It's cheaper, and all lipoic acid, that's good lipoic acid, is absorbed very high in the digestive tract, and you can smell it in the urine 15 minutes to 20 minutes later. One thing, if you take oral lipoic acid, you must take B-complex vitamins with it, because lipoic acid depletes the B-complex vitamins from your body, and you need B-complex vitamins for various methylation cycles. And if you don't have that, and you take too much lipoic acid, you might possibly cause DNA damage and mutations, and maybe cause cancer.
Would you need to be under a doctor's care?
I believe so. And you have to have a doctor who knows what he's doing. Yes.
Concerning the use of LDN, but also the colitis, I've seen various publications talking about 4.5 milligrams as the standard general dosage. In other places, they talk about starting at a lower dosage, such as 1.5 milligrams per day, and then bumping up. What's your recommendation?
Well, it depends on the person. You know, we usually start at 3 milligrams at bedtime, but then some people will complain that they have insomnia from this, or they have wild dreams that keep them awake or wake them up. So we'll go to half the dose, 1.5 milligrams at bedtime, and when they get used to that, we'll go up to 3 milligrams. And then, if they can handle it, 4.5. My patients, there's no set protocol. What I do is I tailor the protocol to the individual patient. this becomes complicated. Lipoic acid, in order to get it into a parenteral solution for intravenous or IM dosing, you have to dissolve it in an alkaline solution, and often the solution is sodium hydroxide. Then you have to buffer it down, because lipoic acid in an acid environment precipitates. It won't dissolve in water. So the normal compounding lipoic acid for intravenous dosing has to be injected into a bag of D5W or normal saline or lactated ringers, at least 100 to 250 milligrams. Otherwise, you're injecting an alkaline solution in somebody's blood vessel, and you can cause very serious problems. And I just got off a coroner's committee where somebody had killed somebody by injecting lipoic acid into their bloodstream without diluting it. It was just like injecting sodium hydroxide in somebody's bloodstream. You really have to know what you're doing. In Europe, one of the prescription products is lipoic acid plus trometamol. Are you familiar with trometamol? This is a hydrocarbon that dissolves the lipoic acid in a neutral state. And this can be given to people intramuscularly, but it's at a very low dosage. It's like 25 or 50 milligrams per cc. So you really can't get up to the high doses if you inject it IM. If you try to inject regular compounded lipoic acid IM, you're going to swell up the person's rear end and cause a lot of pain. If you do it intravenously, you could kill somebody. And you can't mix lipoic acid with anything in an IV bag because it'll cause precipitation. It has to just be lipoic. You mean the pH of the alkaline solution? I'm not sure, but it's high. With the people we've had with pancreatic cancer, with certain neuroendocrine aspects, carcinoid aspects, these people, from my experience, seem to do the best on this protocol. But what I would do is first see what the big medical centers can offer you in an A level. Okay. Well, we have very good results with that kind of a thing, but our patients with that type of pancreatic cancer, this carcinoid, when we send them to oncologists and they put them just on somatostatin A, they may do well for a while, but then the cancer comes back. And with the low-dose naltrexone plus lipoic acid, as long as they're doing this, with some of our patients, they've gotten completely well. I work with an oncologist in El Paso, Texas, quite a bit of the time, and a local one too. And they're amazed at what's going on here. What I said is, if somebody's really sick, we encourage them not to come. But if somebody can travel and is feeling good, feeling fairly normal, we're usually glad to see them. And we always give the recipe for what we do to your local doctor or a doctor in the community who might want to continue it. Well, I think that most people, when they have pancreatic cancer, go to a large medical center, and the The common treatment is gemcitabine, and maybe another a chemotherapeutic agent. And personally, I've never seen it work for anybody. And they often get sicker and are told to go to hospice. And some of these people arrive at our office. I think we get the worst people. And I don't encourage anybody not to get chemotherapy. Say, talk to your oncologist and then educate yourself on the various treatments. And if chemotherapy, if they say, 50% of the people will do well on chemotherapy, I say do it. But if they say the chemotherapy may help you for a while, and maybe in a few months, may give you a few months, say, well, I would try something else, but it's up to you. I don't think the doctor is the boss, it's the patient. And a wise patient educates himself. Many doctors thought that certain types of autoimmune disease had some bacterial involvement, such as a mycoplasma or a chlamydia, an intracellular bacterium. And many rheumatologists have found that by adding an antibiotic often makes people feel better. That's why I do it, and I found that to be true. I usually will start with minocycline, 100 milligrams a day. Make sure they take an acidophilus probiotic. And after a while, it doesn't seem to work as well, and I change to something like erythromycin for a while, and then I go back to minocycline and maybe erythromycin. 2-week stay is always better than a 1 week. I would count on it. We had a few years back, we had a gentleman come from Senegal, and he was the Grand Khalifa in Senegal, and he came with his bodyguards and his cooks and his wives and the whole group. Like, he had first gone to a hospital right here in the Washington area, very prestigious place. They told him they couldn't do anything for him. To go back to Africa, you're going to die. And one of the doctors there told him, go to New Mexico, I think he could help you, but don't tell anybody at the hospital that I told you because I'll get fired. And he stayed for 3 months. When he came, he couldn't walk. He had severe diabetes. He couldn't walk because of the neuropathies. Couldn't read because of the retinopathies. In 3 months, he was reading again and walking. So I think he stayed the longest. But people usually stay from a week to a month. And then we've had many people move to the Las Cruces area because they couldn't get treatment anywhere else, and they live there now. Lipoic acid also modifies gene expression by interfering with various transcription factors, the best known as NF-kappa B, which turns on the growth of cancer cells, which causes the cancer-type inflammation. And in that way, it seems to retard the growth of cancers. It also restores T cell function. This has all been proven. If you go to the National Library of Medicine website and you type in lipoic acid, you can see thousands of studies, abstracts of thousands of studies, and the various things it could do. If you go to Google and you type in lipoic acid, you see lots of information and some actual full-text publications in this area. If you go to Google and you type in Berkson B M like Martin. Many of my full-text publications will pop up in various areas in microbiology and medicine, different areas, cancer. Nobody knows these things for sure, but I know it modifies gene expression when you treat a person with cancer. And I don't know how the body knows, but I suspect it doesn't cause new angiogenesis in cancer cells. We follow these people every couple of months with CAT scans or PET scans and laboratory work, and it's an ongoing process. I have one professor who comes in with spinal stenosis and cauda equina syndrome, where you get numbness in your buttocks and partial paralysis of the legs and paresthesias in the legs. And he claims this is working for him. He's just on low-dose naltrexone and a nutrition program. Some people like it for osteoarthritis. I don't know if it works or not. But for the autoimmune type syndromes, like ankylosing spondylitis, theoretically it should work, and we have a few people that it seems to be working on. I don't know. You might want to check in the American College for the Advancement of Medicine website and see what doctors in Canada are doing this kind of work. I was a very good friend of Hugh Reardon. I don't know if you know the name. And Hugh Reardon did much of the high-dose intravenous vitamin C work. We're friends for many years, and I spoke at his conferences, and he visited my office and stayed with me for a week and saw what I was doing. And he decided to start combining lipoic acid with vitamin C. And he said he was getting some very good results. You give vitamin C intravenously in the morning and lipoic acid in the afternoon after somebody had something to eat. And the vitamin C that was still in the bloodstream, after it was used up, was recycled by the lipoic acid. So he got like twice the bang for his buck. And I do that sometimes too. Lyme disease. We have Amish people and Mennonite people from Pennsylvania coming out all the time to be treated for Lyme disease. And folks from out east, we have probably 100 people with Lyme disease. And I'm a microbiologist originally. My PhD's in an area of microbiology. And I look at diseases caused by microorganisms probably very different. I look at it like a PhD rather than an MD, necessarily. I'm a big believer in antibiotics during the acute phase. But I think every organism that we ever get sick from, even after treatment, is still in our bodies. And as long as you take good care of yourself and you do certain things, these things don't manifest themselves, and you're fine. For years, I volunteered at Rutgers University to teach the field courses. So I was always out teaching field zoology and field botany in the woods of New Jersey and Pennsylvania and New York. And I was bit by deer ticks all of the time. And for a while, I'd have joint pain, and I'd forget about it and take good care of myself and do certain things. From time to time, I take erythromycin or doxycycline, and it seems to control it. But we sort of have a program for Lyme disease, and most people do very well. I don't believe in intravenous antibiotics until it almost kills you. I think there's a way of using antibiotics. I think the perfect example of this is a viral disease, and it also it can be used as a model for certain bacterial diseases. Is, when we're kids, we all get chicken pox. Sometimes we don't know it. We just get a few vesicles, but we get chicken pox. And we get sick, and our immune system beats up that virus, the chicken pox virus, sends it to a ganglion along your spine, and keeps it dormant. But as an adult, if we all have the chickenpox virus in our bodies now. As an adult, if you're under a lot of stress, physical or mental, emotional, for long periods of time, the virus becomes active and causes shingles. But when the stress goes away, your immune system beats the virus up again, sends it to its room, locks the door, and we don't have shingles anymore. But if you have post-herpetic syndrome, post-herpetic zoster syndrome, you continue to have the pain because of the stress. But once you break that stress, it often goes away. Same thing with Lyme disease, which is caused probably by several different parasitic organisms, protozoans and bacteria. It becomes active when you're under stress, and usually when you're calm and happy, you don't have the problem. In European lipoic acid?
That's something I'm going to find out now because of what you're saying.
Very important, because most of the lipoic acids that I see have the cheapest junk in them. A few have wonderful products. And if you take a tablet, I don't like tablets either. I like capsules. Because if you take a tablet of lipoic acid, they put it under heat and pressure, and they probably destroy and change a lot of it. If you're getting too much, you have to take an awful lot to get too much. Like, we never go above 15 milligrams per kilogram, 15, 1-5. And it takes about 90 to kill somebody. So that's a tremendous amount of lipoic acid. But the amount I prescribe for you is enough. Lipoic acid is the king of all, the captain of all antioxidants in the body. It does so many things, and it's such a small molecule, and it's so active. It's just a magnificent natural molecule that we produce. I wrote a book with some co-authors several years back called Syndrome X. I don't know if you're familiar with this. And a basis of this is that, we're very similar physiologically and anatomically to our ancestors from hundreds of thousands of years ago. So we're basically Paleolithic animals. And our bodies were designed to eat vegetables first, meat second, carbs and fats third. And most Americans, like flying in yesterday, everything in the airport, almost everything in the airport was carbs, salt, fats, meats that have been altered, and hardly anything in the way of green vegetables other than lettuce, which has practically, it's like drinking water. So with our patients, I always suggest, especially if you're sick, 4 servings of green vegetables a day. It's the most important thing. I also suggest staying away from fake foods like margarine or any kind of fake sugar. Stick with, if you want a little sugar, it's fine to have some raw sugar in small amounts. Butter is is a good product. Many fake butters contain acrylamides and aflatoxins, which are potent cancer-causing agents. If you go to the National Library of Medicine website and you type in aflatoxin, which is a fungal product a fungal toxin that grows on grains in storage that certain margarines are made from. See hundreds of publications that show that some fake butters, or maybe a lot of fake butters, turn on cancer genes. They trigger the growth of cancer. But if you type in the fat and butter butyrates in cancer, see hundreds of publications that show that butter turns off or helps turn off cancer genes. But you don't hear many people talking about that. Then for sugars, you know, when the body expects sugar, trillions of metabolic cycles occur. And these cycles run on simple carbohydrates in small amounts. If you take in something like a fake sugar, it's like taking a monkey wrench and throwing it into very delicate machinery. And you have all of these, as a metaphor, these gears with fine teeth on them. These fine teeth break off and fly all over the place and injure other cells and genetic material. And this is a metaphor for free radical damage caused by foods that the body isn't meant to metabolize. Here's the problem. I believe in capitalism, by the way. And I think I believe in medical freedom, too. I think people should have the choice, after educating themselves, to choose what doctor they want to go to or what treatment they want to have. And when I have a patient that tells me that they don't want to do what I suggest, and they want to have chemotherapy for like pancreatic cancer, I say, go ahead and do it. You know, do whatever you want, but after you educate yourself. I think that with LDN, for example, I know more about ALA because I was the FDA principal investigator for that for 23 years. If something is inexpensive and it does a lot of different things and it's going to cost a pharmaceutical company money, why would they invest in it? I mean, these are businesses. And with LDN, it's inexpensive. I believe it interferes with the sale of some very expensive drugs. These biological response modifiers cost thousands of dollars, tens of thousands of dollars a year. And this is very inexpensive. So how somebody once told me not long ago, I gave a lecture, and it was at the National Cancer Institute. And one of the doctors there said, you know, this is really amazing stuff, but you realize LDN, the National Cancer Institute, you realize that LDN and lipoic acid will never catch on in America unless we have a depression and everything falls apart. Well, I don't want to see that. I'd rather have it not catch on. And people, I think in medicine, like everything else, it's buyer beware. You should educate yourself and know all of the possibilities and then choose what you want to do. Education, and you have to be able to talk to your politicians who make policies. But I've had no luck doing this. Zero. Just zero luck. Because, you know, politicians are supported by businesses. And they can't cut off the hands that feed them or bite the hands that feed them. I think a grassroots program might work. I wish there was some money available for myself to do large-scale studies at one of the universities, but there doesn't seem to be. And then I have patients who are, I have some patients that are billionaires from Hollywood and millionaires, multimillionaires from Texas. And they're willing to put money into this. But whenever a very wealthy person wants to help you, they always want more from you than they want to give, even if they want to give you millions of dollars. I found that out. All I have is our case histories, and most of them are published, or many of them are published. I have another paper coming out in December of 3 more patients. And I think everything starts with case histories. They don't start with large-scale studies. You have to have the case histories first, and then you have to get the money for the studies to develop the data. But I think there is enough data out there. There are enough data out there that, you know, if a group of people want to get together, we can get this together and publish some very interesting papers.